Hello, I'm Dr. Doug Dietrich. I'm Professor of Medicine at the Icahn School of Medicine at Mount Sinai and Director of the Outpatient Hepatology at Mount Sinai Hospital in New York City. Welcome. Welcome to this program on the treatment of the patient with HIV and hepatitis C co-infection. Joining me today is Dr. Daniel Fearer, Assistant Professor of Medicine and Head of the Co-Infection Clinic for the HIV program, also at Mount Sinai Hospital in New York City. I'd like to mention that this program will include a discussion of off-label treatment options and investigational agents not approved by the FDA for use in the U.S. Before we begin our discussion, please take a moment to test your knowledge on this topic by answering a few questions. You will have another chance to answer these questions at the end of the activity to see what you've learned. Okay, Daniel, let's talk about the case.
So this is a case of a 47-year-old man with asymptomatic HIV infection. His HIV was diagnosed about 24 years prior to his presentation to us. He's never had an opportunistic infection, although he had herpes zoster. He was treated with multiple different antiretroviral regimens over the years, but most recently with tenofovir, didanazine, and boosted atazanavir. He'd been on the didanazine for at least 12 years.
Does that surprise you that he's been on DDI at the present time here for this long?
It is unusual, and it was a surprise, and it was something we will have to deal with as we go forward in this case. Of note, and possibly related to that didanazine you alluded to, he's had a recent slow decline in his absolute CD4 count, down to approximately 100, although his percent CD4 was quite good. So the story began with his hepatitis C infection about 11 years prior, when he was found to have actually a large elevation in his LFTs, and his antibody to hepatitis C was newly positive. At the time, he felt too ill to get treated. He thought that the treatment as well was too toxic. In fact, he had two friends who tried to kill themselves. Over the years, though, he had no signs or symptoms of chronic hepatitis C or liver disease. And although his physician was working on it for many years, he was then finally able to convince him to get engaged in hepatitis C care and came to see me. Further social history that might complicate his treatment was that he is a flight attendant and flies the Southeast Asian routes. And so he's gone for a week at a time and some very difficult working conditions. His review of systems was otherwise notable for urticaria that was a result of anxiety.
So you don't think the urticaria was hep C related?
It did not seem to be. On physical examination, he was a little bit overweight with a BMI of 28. He had no jaundice, rash, bruising, or petechiae, or other skin manifestations of chronic liver disease. But he did have mild bitemporal wasting, had a precervical fat pad that was fairly prominent. Now, no thyromegaly, and his abdominal exam did not show enlarged liver or spleen.
Well, certainly the bitemporal wasting and the precervical fat pad are good reasons to think about stopping the didanazine.
Yeah, exactly.
Among many others.
So his initial laboratory evaluation showed that he had a genotype 1A, or most common genotype, and thinking about interferon treatment, the IL-28B polymorphism was TT. Platelet count at the time was okay, 158,000. His AST a little elevated at 74, normal INR and albumin. Now, the HEPA score, the proprietary mix of serum tests with age, was quite high, 0.95 out of a 1.00 at the top range. Unfortunately, he was immune to hepatitis A and B.
That's a good point. We always need to vaccinate people for A and B, and it's amazing how many escape vaccines for those two diseases.
Yeah, I check it compulsively on the first meeting for that reason, because even though we assume that everyone has been, really many aren't. So he was engaged in discussion about treatment, and over time didn't want to get treated immediately, and so he comes back at 15 months later with a HEPA score that may be arguably even a little higher at the absolute top, and now his platelets are low.
So what does that HEPA score translate to in terms of fibrosis stage?
Yeah, so this is the Quest test, and this gives about a 45% or greater chance of cirrhosis, and if you throw in F3 or F4, it's about 80% chance of very serious liver disease. And then with his platelets low and the AST now higher, quite worried that sort of confirmatory evidence that he has cirrhosis and possibly early portal hypertension.
Yeah, I think platelets less than 120 or 130 are almost pathognomonic for splenomegaly and portal hypertension. So that's a really good, that's a poor man's liver biopsy for cirrhosis. I think that's probably a good sign to think about. So are we satisfied that we've fully staged the patient's liver disease and performed all the necessary safety screenings?
Right. So although it may seem on the surface that we've established that it's cirrhosis, no, we need to follow up one other thing in him, which is hints that may have concomitant steatohepatitis or other sequelae, perhaps of DDI, other liver disease. And we also, very important, need to screen him for hepatocellular carcinoma.
So what would be your next steps? DDI is well known to cause fatty liver. His BMI is 28. He doesn't seem to have diabetes, so he doesn't have any other classic risks for fatty liver disease, except for the DDI.
Right.
So what do you want to do?
Well, in this case, decided to do a liver biopsy to investigate just that, and also the other possibility with mild portal hypertension, maybe it was complicated by the less common syndromes of non-cirrhotic portal hypertension.
It's always possible. Now, we typically don't do liver biopsies purely for fibrosis staging purposes, right. But in this case, I think your point of non-cirrhotic portal hypertension would be well taken. And in addition, we've got other things to think about here too, like the fatty liver and what the DDI has done to his liver.
Right. So the liver biopsy results were quite interesting. He had slight fragmentation of the tissue when the biopsy needle came out, and there were scattered foci of parenchymal necrosis, no significant portal chronic inflammation, and no interface hepatitis. But there was a fair amount of portal fibrosis with septi, and this was also seen on the trichrome. And what we found was something we were worried about, which was pericellular and perisinusoidal fibrosis with a chicken wire configuration.
So typically when you see fragments like that, when the liver biopsy breaks up, it's also pathognomonic of, or almost pathognomonic of cirrhosis. But chicken wire configuration is actually even more interesting. What does that mean?
So that is an indication of prior damage of in this case, most likely to be from steatohepatitis, not a characteristic pattern for hepatitis C-induced fibrosis, which is in the periportal range. So
right. But its fatty liver can be caused by anything.
Absolutely, it does not make that diagnosis.
It could be diadenosine, could be alcohol, could be diabetes, insulin resistance.
Right.
It's just pathognomonic of fatty liver for some reason. So. I guess the interpretation of these findings, Daniel, consistent with the pathologist readings. So cirrhosis, chicken wire fibrosis, fatty liver disease.
So not just liver damage from his hepatitis C. So his liver disease is worse, probably due to his DDI. Although he had gained a fair amount of weight in the interval period as well of observation, and so this adds to perhaps some of this was non-alcoholic steatohepatitis in his past.
You always have to consider, too, if someone's a flight attendant, the alcohol is free. And you should never dismiss alcohol as a cause of, some of these fatty liver, because it could be mixed. It could be any of these or all of the above.
Right. So this is important to address because even when we ultimately cure his hepatitis C, we'll have to deal with the other liver disease. And I thought that was an important reason to address these in this man.
Any other tests that you want to do?
Well, we need to screen him now for hepatoma. And in this case, performed a sonogram. And on the sonogram, the liver was normal in size, but his spleen was a little bit enlarged, about 16 centimeters, not a lot. But
that's certainly consistent with portal hypertension. Yeah. Now, typically, in the liver division, if we see that somebody has cirrhosis, either by low platelets or by biopsy here, we would probably, sort of upgrade our HCC screening to either CT scan or MRI, because the sonograms, particularly in cirrhosis, are much less accurate and they can't see small lesions. And of course, we want if there's a lesion there, we want to find it when it's small. But I don't remember his alpha-fetoprotein as being abnormal.
It wasn't particularly elevated. It was in the range of the people who have cirrhosis. So the first test was a sonogram, and subsequently the screen with more sensitive tests.
Right. So even though alpha-fetoprotein is not part of the guidelines, we tend to do it as a little help. And if we see it rising, that's another reason to switch from ultrasound to CAT scan, even though it can rise in advanced liver disease without any tumors, but we've seen so many more tumors and so many more hepatomas in co-infected patients. The prognosis is so much worse, and they do get discovered so much later that we're really very sensitive about screening for hepatoma in our co-infected patients. So, does this patient need treatment now that we have him completely staged here? And would you treat him now in early 2014, or would you wait until the end of 2014 or early 2015 to treat him?
So you bring up a really important point that we should state explicitly, which is we're talking about 2014, which is a few months from now. And I think that the important thing is we believe with his cirrhosis, it also looks like it's relatively rapidly progressed. We think he probably only had hepatitis C for a decade, that we really do need to get him cured quickly. That said, we will not use the drugs that we have today in hand, which is the current protease inhibitors, but are looking toward sofosbuvir, in his case more likely rather than simipravir, to use with or without interferon. So that it's really the question of whether we should treat him. Perhaps we have a few choices with 12 weeks of interferon ribavirin and sofosbuvir in the first quarter of 2014.
Now remember, we can't use ribavirin if he's still on the didanosine.
Very good point. We didn't address
the didanosine.
Yes. One of the first things we did was to change his antiretroviral regimen.
Okay, good.
So that was
relatively easy. And one point we should make too, just as a general point about treatment of Hep C in HIV patients with direct-acting antivirals. Every study we've done with telaprevir, boceprevir, faldaprevir, simipravir, and most recently with sofosbuvir has shown exactly the same cure rate, exactly the same SVR rate as in our patients with monoinfection. So HIV has absolutely no detrimental effect on the SVR rate. So there's every reason to be treating our co-infected patients now because the success rates are really very, very extraordinary.
An important misapprehension to get over. I think we got really stuck in the era of some of the studies that you were very important in, where we saw in genotype 1 the SVR rates of 20%, and it was a year of sort of torture. It seemed hopeless, and so a lot of HIV docs did sort of turn off and say, we can't do that, along with their patients, as wasn't the case here. Now, our HIV-infected patients should be cured just as easily as the HIV uninfected. So yes, as an advocate from the co-infection side, very important.
So our treatment options are sofosbuvir with PEG and ribavirin, even though it's not been studied in co-infection. It's been studied in monoinfection, and the SVR rate was 90% for that monoinfection, so we would expect something similar, maybe a little less, 80% in cirrhotic patients. We also have data on sofosbuvir for 24 weeks. In co-infection, that was the PHOTON study.
Interferon-free.
That was just sofosbuvir and ribavirin for 24 weeks. That was 76% SVR, which was actually also quite impressive. And then, of course, there's always simipravir. That's available. That we can't use that with our boosted protease inhibitors or with the non-nukes. And we can use it with raltegravir and probably dolutegravir and PEG and ribavirin. And that showed a very good response rate, actually, as well. And maybe by the end of 2014, we'll have faldaprevir, but that's also, at the moment, being used with PEG and ribavirin. So our big question is, and of course we know the fixed-dose combination of sofosbuvir and ledipasvir will be available at the end of 2014, and the AbbVie combination of 5 drugs will be available then as well, although that's got a ritonavir boosting, and we might have to change antiretrovirals. So I think our big question is, do we need to treat them early 2014 or late 2014?
Right.
And I think the emphasis may be on the late. So what do you want to do, Daniel? Treat them now or wait?
Well, I think some of this put to the patient a little. We have some patients who are so fearful of interferon that we would push them off. But I think that early is better. And I think that this one we could make a strong case for giving them a 12-week of interferon ribavirin sofosbuvir, and maybe consider giving them sofosbuvir monotherapy, knowing in the lower proportion that will fail that, we'll have to go back and retreat.
Yeah, I think both of those are perfectly reasonable options. And even if we fail, in the small chance, the 20 or 25% that fail, there's no resistance penalty to pay because the S282 resistance mutation caused by sofosbuvir seems to be very unfit and goes away almost right away. And you can retreat those patients later with sofosbuvir plus ledipasvir or the all AbbVie combination later in 2014 if by chance it doesn't work. So I think the point is we need to treat this gentleman now before he develops an HCC that's in the wrong place and we can't fix it, and before any more steatohepatitis occurs, whether or not. And of course, the big thing is we have to get him off didanosine.
Right. Done.
Okay.
Yeah. A high priority.
Deal. So I think we should treat now and think about this. Daniel, thank you for joining me in this interesting discussion today. I think it was a great one and a complicated case, and we hope we'll have a great outcome with this one.
Yeah, it was a pleasure to be here, and it was a great discussion.
And thank you for participating in this activity. Please click on the Earn CME credit link to revisit the questions presented at the beginning of this activity and see what you've learned. The CME post-test and the evaluation will follow.